doing right now. In this third final session, we have another 6 nursing students who will be presenting their work that they did. And so judges, just like before, I will be giving you the presenter ID number that can go on the top of your judging form. All attendees are muted throughout this session, and you can unmute yourself when it's your time to present. And if you forget, I will make sure to unmute you. A 1-minute warning will be given if it is needed so that you can know to wrap things up. If you have questions or comments, please put them in the chat room for everyone to see. Ms. Harold will read those questions off as needed, and then if not, we will have you answer those questions if time has run out. So let's get started. Our very first presenter for session 3 is Alexandra Wood, who also goes by Nikki. Judges, her participant ID number for your form is number 15. And she is presenting her work entitled, "What are methods to ensuring patient safety in the operating room?"
Okay, am I unmuted?
You're good.
Okay. Let's see. Okay. Hi, I'm Alexandra, or Nikki, like Ms. McMillan said. My presentation is on what are methods to ensuring patient safety in the operating room. Okay, my first article summary is on preoperative care. It's hard for me to read because this is in the way. Okay, there we go. The preoperative care performed by a nurse is the first phase of a patient's perioperative experience. The preoperative assessment, which consists of intense information and questions that assist with defining patients' vulnerabilities or risk factors for poor surgical outcomes, is a critical point of care trajectory as the patient transitions through the perioperative phases. The preoperative assessment ensures the patient is correctly identified, the patient has adequate knowledge of postoperative teaching, the patient is not currently on any medications or has any allergies that would put them at risk during surgery, and the patient is safe to transition to the next perioperative phase. One of the studies that I did was performed to identify nurses' contributions to transitions in care as patients move between care settings in the perioperative environment. The results showed that the nursing preoperative assessment can be useful in identifying and defining patients' risk factors and vulnerability, not just for surgery, but for the entire perioperative care trajectory. And this is just an example of the preoperative checklist that you would do before the patient goes to surgery. It would ask stuff like, is the nail polish removed? Has their skin been prepped? Are their contact lenses out if they wear any? Okay. Next is intraoperative care, or the care that's done during surgery. The operating room nurse is responsible for ensuring patient safety during surgery. To increase patient safety during surgery, reduce surgical complications, and improve interprofessional teamwork during surgical interventions, the World Health Organization introduced the Safe Surgery Checklist. The SSC includes a sign-in, timeout, and sign-out, which are brief breaks taken before, during, and after surgery to discuss important details relating to ensuring patient safety. A study was conducted to understand an operating room nurse's experiences and opinions pertaining to how the team executes and follows the SSC procedure to determine if other challenges related to culture in surgical teams are present. The results showed that the SSC execution influenced teamwork and patient safety in both positive and negative ways, but it ultimately, when executed correctly, the SSC prevented adverse events and errors. And this is just an example of what a surgical safety checklist would look like. You do before the incision, before induction of anesthesia, before the skin incision, and before the patient leaves the room. Okay, last is my postoperative care, which is after surgery. Surgical site infection is a major concern postoperatively amongst those in the perioperative team due to it leading to prolonged hospital stay and putting the patient's safety at risk. Sterile technique must be performed by all sterile personnel included in the perioperative team in order to reduce the risk of surgical site infection. It is crucial for the surgical team to follow and perform surgery protocols during surgery in order to prevent certain postoperative complications. A study was performed to evaluate the use and knowledge of sterile technique on perioperative nurses. The results showed that though the nurses had excellent knowledge and use of sterile technique, reinforcement teaching was still needed periodically for a refresher. And that was just a picture showing, the surgical asepsis and medical asepsis. And then my relevance to nursing. The nurse is responsible for ensuring patient safety during surgery by getting the patient ready for surgery. This can be achieved through conducting a detailed preoperative assessment. Also, the nurse is responsible for ensuring that the patient has a smooth and successful perioperative transition. Nurses also have a huge responsibility in ensuring patient safety in the operating room. This responsibility ranges from ensuring that the patient's identity is periodically checked to maintaining the patient's proper positioning throughout surgery. The nurse is also responsible for ensuring the safe surgery checklist is performed. Lastly, nurses are responsible for knowing the proper ways to prevent infection, whether it be through a non-sterile technique such as hand washing, before and after entering a patient's room, or through a sterile technique such as maintaining the sterility of a field by not allowing a non-sterile item or person to come into contact with the sterile field. And any questions? And this is my references. Okay, let me see.
So did you learn anything new from your research that you didn't already know?
Yes, I did. The reason why I chose this is because I love being in surgery, and in MedSurg 1, we were able to go through surgery and see this. And I learned about the safe surgery checklist, everything that's exactly on it. It's actually fascinating how much is exactly done during surgery, and it's just done so quick that you don't realize that it's all being done, but how the team, works in a motion together that they just are used to doing it. They can do it so quickly.
Are you interested in going into surgical nursing?
Yes, I did want to do that, but I did end up doing critical care, so I might see some stuff going on with surgery there.
Oh, yeah.
Thank you, Nikki. Good job. If there's any other questions that come up on chat, if you'll just make sure to answer those, please.
Yes, ma'am.
Okay, we will move on to our second presenter, Eva DeVille. Judges, her participant ID number for you is number 17. Eva is presenting her work entitled Alternative Therapies. Are nurses knowledgeable, and are these therapies effective in controlling pain? When you're ready, Eva.
Okay, everybody, I've been having some technical issues, so just bear with me. Okay. And like Ms. McMillan said, I'm Eva, and my topic was alternative therapies. Are nurses knowledgeable, and are these therapies effective in controlling pain? So, alternative pain therapy techniques have become a large area of interest in today's healthcare system. As new research supports the use of complementary and alternative medicines, it is vital to determine the use of these practices by nurses in the acute care setting and how effective these techniques are. There are many forms of alternative pain therapy that can be performed, such as healing touch, music therapy, TENS, deep breathing, massage therapy, imagery, and distraction. Research from multiple sources in my lit review concluded that nurses support the use of these therapies, but they don't necessarily use them consistently and only perform a select few of the many techniques available. I found it particularly interesting that in one research article, it stated that only about 6.7% of the nurses that actually use non-pharm techniques in their daily care, and it was mainly only turning their patient, and this was in an ICU setting where their patients could definitely benefit positively from using some form of technique. The most common barriers that the most common barriers to using alternative pain therapy techniques when interviewed nurses were knowledge deficits, workload issues, time, and patient conditions. We all know how hectic it can be on the floor as a nurse when you're caring for multiple patients at a time, but being a nurse, we have that responsibility for caring for our patient. If that means using some kind of alternative therapy, then we need to do it if it takes a couple of minutes. Continued education is a key factor in promoting the use of these methods and assisting nurses with proper instructions to perform these techniques during patient care. So during my literature review, I particularly focused on 3 forms of non-pharm techniques, which were music, massage, and healing touch, and these were the results from those particular research articles. For music therapy, it focused on the effects of post-operative orthopedic patients, and it showed that significant positive effects were observed from the experiment, showing a 73% of improvement for patients' pain using some form of musical therapy, either that be from a musical therapist or even CDs played during surgery and after surgery. For massage therapy, it was a systematic review that was conducted to research the effectiveness of different massage methods on post-operative cardiac patients. Some of the forms of massage were Swedish massages, foot massages, integrative massages, and hand massages, but there was not enough evidence to support the use of massage. So that's why it's so important to research these different therapies just to see and have the data to understand how effective that they are. And then lastly, healing touch. Experimental research was conducted with 11 nurses in a focus group to determine personal experiences using healing touch and effects on patient care. And nurses reported that healing touch made a positive impact on their personal lives and decreased anxiety or reduced suffering for patients. For relevance to nursing practice, alternative therapies allow nurses to treat clients in a holistic approach. Nurses tend to forget the mental and spiritual aspect when they're caring for your patient, and certain alternative therapies such as healing touch enable the nurse to effectively tend to the mind, body, and soul. The number of individuals that are experiencing some form of acute or chronic pain is on the rise. So this means that nurses have the responsibility of using non-pharmacological techniques in conjunction with prescription pain medications to comfort patients and reduce pain. These techniques are typically quick and painless, making them ideal for almost all patients, and they're usually free as well, which can benefit the hospitals. Using alternative pain therapy methods provide a means to fight the opioid pain medication crisis. Nurses are at the front line of this issue and have the responsibility to fight back. So implementing non-pharmacological techniques allow for continued research to occur regarding the effectiveness of these methods and how they can reduce the amount of prescription painkillers that are being used. So this is just a picture of some of the different techniques that can be used and that I discussed, like healing touch and music therapy, the TENS unit that can be used. And that's my references. And any questions?
Nice job. First question is, what is a Swedish massage?
Okay, I had the same question and I had to look it up. It's kind of difficult to explain. It's kind of like a back massage is what I would say it's like, would be the most common thing I could compare it to.
Okay. And what do you think is the main reason that nurses forget to use non-pharmacological pain relief?
I think it's specifically time and just workload issues. Nobody thinks like, hey, I need to go in here and give somebody a massage because they think other things are more important. But like I said, it may not just be physical pain, it could be something mental. So just going in and talking to your patients and performing some technique like this can really connect you to the patient, so it can help overall.
Good. How do you think that you'll apply what you learned into your personal practice?
I feel like personally, I know the effects of opioid prescriptions and how that can affect someone. So just knowing how that can affect someone and bringing that into the hospital setting and maybe trying an alternative therapy before prescription pain medication can really improve somebody's life in general and after they leave the hospital.
I agree. Do you think that these techniques are implemented enough in the healthcare field?
Absolutely not. I feel that nurses kind of push them to the side, and they also feel that maybe that's not in their scope of practice, that somebody else has to perform some of these techniques, but it's not true. You can do them yourself, and it can make a big impact.
In your experience, have you, oh, go
I'm
ahead.
going to stop it there. Sorry. Again, if you'll just answer any remaining ones on the chat, if you can see
Okay,
them.
thank you.
Good job. Okay, next we're going to move on to Jennifer Edmondson. Judges, her participant ID for your form is number 24. Jennifer is presenting her work today entitled, "Are Nurses Providing Accurate Pain Management and How Can It Be Improved?"
Hi, as Ms. McMillan said, my name is Jennifer Edmondson. My topic today is, are nurses providing accurate pain management? So let's see. So this is one of the most common types of pain scales that you see in the hospital. So you see the faces or just the 0 to 10. The nurses always say, what's your pain scale, 0 to 10? So let's see. Okay, so my articles, we all had 6 articles to research. So from my research, I found that nurses can really improve on pain management. There are many different barriers, such as physical and verbal barriers when it comes to patients in pain. So some patients are verbally impaired and they cannot use the standard pain scales that most nurses know or use. So this can cause a barrier in adequate pain control when they're not educated on the other measurement scales to use. Another thing that I noticed was continuing education for nurses should definitely be one of the top priorities of healthcare facilities. Keeping nurses up to date on pain relieving measures, both pharmacological and non-pharmacological, like Eva had said, is essential to managing patients' pain before and during it occurring. Many nurses are lacking in this area, and it shows whenever they do the post-satisfaction surveys that hospitals do, and it shows that a lot of nurses didn't try other things, or they just didn't show caringness, I guess. Another thing I noticed was that nurses need to listen to their patients more and understand what they prefer before assuming what they need. A lot of nurses just skip the non-pharmacological pain management first, and they just go to automatically giving pain pills. A lot of times they don't even ask their patients if they're in pain. They'll just do it just assuming. And this is a big barrier that needs to be taken care of. Many nurses need to just fix this. Another major component is having the resources needed to do pain management, whether it's pharmacological or non-pharmacological. In one of my researches, it found that a lot of facilities do not provide their workers with adequate resources needed. Pain management is a critical part in providing adequate nursing care while in the hospital setting. It is the duty of us as nurses to ensure that they are up to date with the most recent pain relief measures. So these are just pictures of some different types of pain relieving measures. You can do therapeutic touch, active listening. Just listening to them sometimes can make them feel better. And then obviously you can do pain pills if they need it, but sometimes you can do it with just listening to them. So this is very relevant to nursing practice because pain is a major component of nursing care. It's one of the most feared parts of a hospital stay. No matter how little or how large the problem is, patients fear this. They do not want to be in pain, as the duty is to us as staff and nurses to care for the patients. Nurses need to be educated regarding different pain relief techniques, like Eva had said, all of the different non-pharmacological and also pharmacological pain reliefs, because every patient is different, so their pain relief is going to be different too. So nurses can attend classes to help with this, to learn about the different types of relief, and so just so that they can stay up to date on appropriate care. Pain can also be indicative of many different problems in the healthcare world, and nurses should practice active listening and good physical assessments to ensure that patients are getting the care that they need to have adequate pain relief. And then here are my references. Okay. Does anybody have any questions?
First question is, why did you choose to research this topic?
Sorry, I'm trying to stop the share. Okay, there it is. I chose this topic because it really is a big part of nursing care. Pain, almost every patient in the hospital has pain. That's one of the biggest things they complain of and what they're worried about more than anything else. So this is something that really needs to be talked about because a lot of nurses don't try to, I guess, think about the patient when they're doing pain control. They're really just doing it to get them to stop complaining. And that is a big stigma that needs to stop.
Okay. Do you think hospitals would benefit from creating and having a pain nurse role? And if yes, how would you advocate for this role?
I think that actually would be a great thing because that one nurse could really go around to see if everything is doing okay with the patient's pain and things like that to help them, because a lot of times a patient will say they're in pain, but a nurse can't get there for another 30 minutes. So it makes the patient's pain not more worse, but worse. So having a nurse like that would be better. But that is kind of hard to do if it's just one nurse for a large floor too. So something like that would have to be a lot of tweaking, working out.
Mm-hmm. Do you feel nurses need more education relating to pain relief, and would it help them better educate their patients?
Yes, definitely. Nurses never can know everything. You can always do better with education. So definitely learning yourself so that you can teach somebody else is essential in nursing, honestly.
Good. Any other questions?
Okay, nice job, Jennifer. Thank you.
Yeah.
All right, our third presenter for this session is Elaine Smith. Judges, her participant ID for your form is number 28. Elaine is presenting her topic entitled, "Why is there a global nursing shortage?"
Myself. Okay, hi everyone. The title of my research is "Why is there a global nursing shortage?" The most common answer to that is the increased number of older nurses who are retiring and increasing number of older adults who need nursing care. Other reasons that are commonly stated in literatures are the physically demanding nature of the job and the increasing workload. Additional reasons why nurses leave are due to work demands, such as working nights or weekends, lack of teamwork, lack of support and respect, inadequate money compensation, and nurse burnout. Most of the time, the issue of the global nursing shortage is focused more on how it affects inpatient care in hospitals, and less on other areas of nursing such as mental health, aged care, emergency department, home health, pediatric, palliative care, and perioperative care. Perioperative nursing, or the OR, suffers in retention and recruitment. It is reported that most medical errors happen in the OR, that cases of hospital-acquired infections are increasing due to decreasing quality in patient care. The greatest concern is safety of the patient in surgery, which is why this field of nursing needs expert and experienced nurses. Retention problem comes from inadequate staffing, bullying by surgeons, nurse burnout. And recruitment problems comes from the lack of interest among new graduates into the OR setting due to lack of exposure during clinicals. Mental and aged care nursing positions in Sydney, Australia are hard to fill, and they have a hard time hiring newly graduated nurses because aged care nursing is viewed as boring, monotonous, notorious for workplace violence, and pay less than other areas of nursing. And mental health nursing is viewed as dirty, basic, repetitive, and less exciting. Emergency departments has a problem retaining nurses. The reasons behind it are stress due to increased number of the aging population having complicated conditions, violence, overcrowding, patient boarding, and pressure to improve patient satisfaction. Home health, pediatric palliative care nursing has a great need for nurses who are qualified to care for children with life-threatening conditions that may result in death, congenital defects that require multiple surgeries, or a relapse cancer diagnosis in the home setting. These patients need complex care because most are on tracheostomy, respiratory, feeding, and other technologically dependent devices. The pediatric home nursing shortage is said to be worse compared to other areas of nursing. This is due to the training required and qualifications the nurses need to have in order to deal with complexity of care that these pediatric patients need. Salary of home health nurses are comparable to inpatient nurses, except that they receive fewer incentives and opportunities for growth. One article that I came across is about the reasons why nurses in New Zealand leave their profession before they reach retirement age. New Zealand's vulnerability to the nursing shortage primarily comes from the fact that 43% of its nurses are over 50 years old, and almost half is expected to retire over the next decade or so. Other factors that play a part in the nursing shortage is the migration of its nurses to other countries like Australia and the United States. They eventually find work in Australia or the US because they are automatically eligible to work in these countries if they are registered nurses in New Zealand. Culture, increased workload, and health-related concerns, loss of confidence dealing with new technology, and loss of seniority and new workplace are reasons why older nurses leave before retirement age. Relevance to nursing practice. The nursing shortage greatly affects patient care, safety, and satisfaction when nurses work long hours. It does not only affect those patients in the hospital, but also in the home, mental, and aged care setting. It also affects the nurses because of the shortage. Nurses are getting stressed and experience burnout due to increased workload. They may also suffer injuries and back problems. Medication errors can also occur when nurses are overworked, which compromise good outcome for the patient. In order to recruit and retain nurses, we need to make sure all nurses feel that they are appreciated and respected in the workplace and the community. They should be given bigger incentives if they want to work in specialty areas that are hard to fill, and those who stay should receive retention bonus as well. And here are my references, and thank you.
Okay, anybody have any questions? Hold on, I'm trying to catch up.
Okay.
So what made you choose this topic?
Well, first of all, when you go to clinicals, I mean, even before as a kid growing up in the Philippines, I always hear, oh, the United States is needing nurses or something like that. So it's always like that. It's like there was never a time that they say, oh, they have enough nurses and something like that, and even other countries. And so when I came here, when I go to clinicals, when I talk to nurses, they will say, oh, we all need nurses here. We all need, so yeah, so I think it's something that we all hear a lot. Yeah, and so when we say, and when we question, when we hear, when they ask about that, it's always like, oh, because, baby boomers are getting old, and, some nurses are getting old too, but, I know that there's more reasons than that or something.
Alex wanted to know what surgery you were able to sit in on.
What surgery? Oh, I did, I think that was adenoidectomy and tonsillectomy and cataract surgery.
And did you find anything in your research about a shortage of nursing faculty?
Yes. it's like so the thing about the nursing faculty is like it's hard to recruit because I don't know if it's true, but they said it pays less. And I also have friends who used to teach in LSUA, and I asked her like, okay, why did you stop? And she's an NP now, and she said, oh, the pay isn't that good. So yeah.
All right, thanks, Elaine. Appreciate
You're
it.
welcome.
Good job.
Thank you.
Okay, our next presenter is Alexandra Sheffield. Judges, her participant ID number is number 29, and she will be presenting her topic entitled Patient Falls and the Implications for Nursing Practice.
Okay, I'm trying to share. Can everybody see that? Can everybody see that?
We can.
Okay, so I'm Alex Sheffield, and my topic is what is the impact of patient falls and interventions on the nursing profession? Why did I choose my topic? Patient falls and their impact on the nursing profession are relevant considering the increasing age of the patient population. And comorbidities and polypharmacy are two of the main factors that nurses will directly deal with when caring for patients, and they are two factors that increase the risk for falls. Summarizing the research, patient ambulation during toileting represents a large percentage of associated falls when combined with medication usage, altered mental status, medical conditions, ambulation issues, and altered elimination patterns. In a survey of registered nurses and patient care technicians concerning their perceptions surrounding toileting patients and associated fall risk, two main issues were noted that impacted the care taken to prevent patient falls in the hospital setting. Patient care technicians, when surveyed, said that medications were not considered when determining fall risk, and using adult briefs or diapers was an appropriate intervention for toileting. When surveying RNs and PC and patient care technicians, they said that scheduled toileting every 4 hours was an appropriate time frame for toileting patients on a schedule. In conclusion, the researchers found that RNs needed to better educate PCTs about the medication-associated risk factors for patient falls and the risk factors for skin breakdown regarding the use of diapers. Also, toileting schedules need to be focused around the patient's own schedule for toileting at home rather than a preset schedule of 4 hours. And that is based on evidence-based practice. Next, preventing falls and ensuring patients reach out for help after sustaining a fall requires that their feelings and needs are addressed before professional interventions can be implemented. Patient needs were as follows: maintaining independence after a fall, so such things as driving a car, socializing in the community, especially elderly people found it was very important that they were able to maintain the lifestyle they were that was normal for them. Not being fearful of barriers to their independence. So forced to be in a hospital, removed from their homes, to be put in a care home. A lot of elderly people will not report a fall because they're fearful of being removed from their homes and, losing their sense of independence. Having access to assistive devices to retain safe, to remain safe, such as Life Alert. So it's like the electronic communication devices, grab bars around the home, assistive devices to walk with, like walkers and things like that. Elderly people reported that having such devices was very important for them to maintain their independence. So even after having a fall or having mobility issues, they were able to continue to live at home and still retain their independence. Being under the care of a doctor and having access to physical therapy after a fall was also indicated as an important issue for elderly people. They stated that they felt more comfortable and confident and able to maintain their independence if they were under the care of a doctor and had access to physical therapy after a fall to regain their mobility if they were injured, which elderly people are more likely to be injured from a fall, and also the risk of death is higher, and because of the decreased physiological reserve, they just tend to remain in a kind of debilitated state for a longer period of time when recovering from a fall. In conclusion, by removing preconceived fears in the elderly population, they are more likely to reach out and obtain help before and after falls, which correlate to better patient outcomes and adherence to medical recommendations. Next, implementing tailored fall prevention clinical-based guidelines has many benefits in the hospital setting. Better knowledge regarding accessing information on evidence-based practices these are factors that increase the ability to implement clinical-based guidelines with the nursing staff, doctors, and everyone on the floor. So they need better knowledge regarding accessing information on evidence-based practices. They have increased availability of fall prevention devices because the research found that when hospitals made a concerted effort to implement clinical-based guidelines, which is a structured program to establish education and to provide the needs of the staff to prevent falls, that there obviously were better prevention of falls because of the increased access to devices, which obviously is a financial issue with hospitals. Increased use of critical thinking skills, where nurses reported thinking critically about interventions as they carried them out rather than just carrying out interventions because they had always done things a certain way. So nurses during this study initially were very concerned about new evidence-based guidelines being implemented in the hospital, and they stated that they felt like it took away their autonomy, but after actually implementing the guidelines, they found that they actually enjoyed it because they were better educated. They were able to critically think and question every intervention they did and said, why are we doing this? What, how does this actually prevent falls? And they found that, that it was a positive thing. The best implementation of a structured clinical practice guideline requires nursing education, structured guidelines, and specificity for the department in which it is being implemented to provide a tailor-made approach. So it's very important when implementing a structured program where it really changes the whole way the team on the floor functions. It's really important that it is tailor-made to that department for it to be effective. There is a correlation between the level of nursing education and the occurrence of patient falls. So in this study, they assessed the level of education of nurses, and they compared associate degree educated nurses to bachelor's degree educated nurses at a magnet hospital over a 6-year period. And it says that falls decrease as associate's degree educated nurses decrease and bachelor's degree educated nurses increase. Patient outcomes may be improved as shown by a decrease in patient falls with the increased education for nursing personnel. There is a value in continuing education as nurses may have better assessment skills, decision-making ability, and general knowledge about evidence-based practice. But it is important to note that this was over a 6-year period, and many of the associate's degree educated nurses in this study actually became bachelor's degree educated throughout the study. So you can't just take this in an isolated way. Like, it could be their experience as well that decrease the incidence of falls at this particular hospital. Fall prevention in the cognitively impaired patients requires evidence-based interventions to prevent the worsening of cognitive decline and physical impairments in the specific population who are at increased risk of falls and injuries. So there were certain activities that nurses were engaged in that had high adherence rates and low adherence rates. And these are evidence-based interventions that should be done to prevent falls in the cognitively impaired population. So in terms of high adherence, they ensured that patients were fed and properly hydrated, that they did safety checks in the rooms, and that they had mobility aids available to the patients. Low adherence, they did not educate about fall risk. They did not do enough pain assessments. They did not take the time to reorient the patients, and bowel care related to treating constipation was not something that they did appropriately. So they made sure that they were able to get to the bathroom, but when patients suffered constipation, they were not there to treat with stool softeners and laxatives and things like that to ensure. And the thing with constipation is that it leads to delirium. So it's one of those factors that really need to be paid attention to, as well as pain contribute to delirium. And obviously, if the patient is not oriented, they're going to have confusion, and that's going to be a problem. And anytime you have a patient who is cognitively impaired, they are at an increased risk of falls. Any issues that increase cognitive impairment or physical disability should be avoided, such as using immobility as a means of fall prevention and not orienting patients, constipation, suffering pain, which all lead to increased delirium. And nurses did report that in certain situations, instead of coming in there and mobilizing the patient, maybe there was a shortage of staff, that they would just use immobility as a method. And that's bad, because obviously immobility leads to other complications in patient condition. Excellent communication skills, specifically among nurses and other leaders on a medical team, are integral to transmitting vital patient information accurately and efficiently to prevent misinformation and subpar care for patients, which could lead to patient falls, as well as an overall inability to implement fall prevention protocols. So various passive forms of communication, such as documentation of patient data or charting, and using the fall risk assessment scale, rather than direct communication person to person of pertinent patient data, can lead to miscommunication and missed information that the nurse should be aware of. Pharmacists on the healthcare team reported utilizing direct communication techniques when reporting medication side effects to doctors, but did not pass that same information to nurses. Implementing evidence-based practice properly requires universal and cohesive communication strategies that allow accurate and reliable dissemination of information. So really, this is about like having a standardized form of communication tools, and that prevents miscommunication. So it's kind of like the game of telephone. You know, if everybody's communicating in a different way, if something is being documented in one place, but it's not being told to someone else, you may miss that piece of pertinent information, and that could end up in a patient having a fall, because if they are taking a medication that is especially risky for falls, or if if a nurse did the fall risk assessment scale but did not report to the oncoming nurse that this patient was at an increased fall risk, well, then that obviously increases the risk of patient falls. Barriers to implementing evidence-based fall prevention protocols include inadequate staffing, inability of the nurses to have eyes on all patients, different protocol preferences for different units, and disagreements on personal responsibility for prevention of falls. In the research, there was a lot of back and forth about whether patient care technicians were responsible for preventing falls, if nurses were responsible, if doctors were responsible. A lot of people were, it was kind of like a little bit of the blame game, like, well, they're responsible in this way because they're ambulating the patients, or, the nurses are responsible because they're the one administering medications. They're responsible for educating about those risks. So it's really important that there is a cohesive understanding that it's everybody's responsibility to prevent falls in the hospital. And implications for nursing practice. So fall prevention is at the forefront of patient safety, as patients are surviving longer with more serious conditions as a result of advancements in medical treatments. Older patients tend to have more comorbidities and mobility issues, as well as take numerous medications that increase the risk for falls. So that's obviously a consideration for most nurses. Education was a common theme throughout the research, and the need for constant education of patients, nursing staff, supportive staff, and families to prevent falls and fall-related injuries. Nurses must understand the psychosocial aspects of patient falls and be prepared to address the needs and wishes of the elderly population in order to best serve them. So it's important with nursing, as we all know, to have a holistic approach. It's not only taking care of the patient's healthcare needs, but also their psychosocial needs. Do they have a support system at home? Do they, what are their concerns and wishes about how their care is carried out? And it's important that we kind of address all those. And somebody else mentioned in their presentation about advocacy, and part of that is taking the time to listen to patients. So not just to go in there and start rattling off all this teaching, but to listen and see what they're concerned with, and let them know that you were there to listen and to advocate for them and their wishes, not just to rattle off a bunch of information that you feel like they need to know. Nurses need proficient communication skills to successfully engage patients, families, and fellow interdisciplinary team members regarding patient risk factors and implementation of interventions to prevent patient falls. And that just goes to, you know, strong communication skills are integral to nursing. And, you know, you have to communicate with a very diverse population, a bunch of patients, doctors, you know, so you really need to have good communication skills to discuss information and ensure that the information is getting across to everyone so that you don't have incidences like falls. And this is just a visual representation of like a tool that facilities can use. And what's great about this is you have a very quick visual representation of individual patient risk factors. So you can look at this and immediately say, okay, oh, they have a previous fall, so I'm going to be extra aware of this. And you can see what kind of walking aids they use, how they go to the bathroom, and a specific time frame for that specific patient, which is so important. And it also, with the bed, you know, with the bed alarm and the assistance out of bed, like how many people need to assist this patient? So it's a quick way so that you can, you know, instead of having to go back to the chart or ask someone, you can fill this out, and it's a good way to have that information readily available. Oh, somebody say something? And these are my references. Okay.
Thank you, Alexandra. If you'll just answer questions, if there's any in the chat room, so we can move to the next presenter.
Okay, sorry.
It's okay, thank you. Nice job, by the way.
Oh, thank you.
You're welcome. All right, our final presenter that we have is Austin Bedevie. Judges, his participant ID number for your form is number 38. And Austin is presenting his work entitled Effectiveness of Patient-Controlled Analgesia versus Other Types of Pain Control.
All right, can y'all see it?
We can.
All righty. I'm Austin Bedevie. I'm presenting PCA versus other pain control methods. So PCA, or patient-controlled analgesia, is a method of pain control that allows the patient to, in a way, control the amount of pain relief they're getting. A computerized pump is used, which contains a syringe of pain medication as prescribed by a provider that is connected directly to the patient's IV line. In most cases, the PCA pump delivers a small constant amount of pain medication, and there's a button that the patient can use to press to get a small additional bolus of pain medication when they are experiencing breakthrough pain. But the PCA pump does have a lockout feature that stops the patient from being able to press the button when the maximum dose of pain medication has been given per hour. So patients appropriate for PCA, post-operative patients that are having severe acute pain, painful conditions such as pancreatitis or sickle cell disease, patients who can't take medicines by mouth, or cancer pain. Some contraindications of PCA are patients who are confused or cognitively impaired, who are unable to use the pump effectively, and unconscious patients. So here's some of the other pain relief options. You have your non-opioid pain medications like acetaminophen and ibuprofen. You have nerve blocks, as well as non-pharmacological pain relief methods. So in a case study, a PCA device was used on 58 patients aged 65 or over in an ortho unit. And when questioned about their PCA pump, 98% were able to locate and activate the PCA pump effectively. 91% were able to correctly answer who could push the PCA button, but only 56% were correctly able to answer how often they were allowed to push the PCA button. So from this case study, we get some nursing considerations. It's important to keep the PCA device within reach of the patient. And educating them is extremely important about who can press the button, how often they can press the button, and generally how the PCA pump works. And it's important to do this pre-op and post-op if it's for surgery, but good teaching is very important. This is just a little comparison of PCA versus other pain control methods. PCA is usually used for acute pain with a severe pain intensity. and pain unrelieved by other methods. But a downside of PCA is that it relies heavily on opioids, which there is a risk for dependency. So another case study, it goes over opioid versus non-opioids medications for pain relief of acute lower extremity pain. So acetaminophen is administered in combination with one of the following randomly selected medications: ibuprofen, hydrocodone, codeine, or oxycodone. So, and their pain scale was assessed prior to medication administration and hourly 3 times afterward. The average reduction in pain with all of these medications was from 3.5 to 4.4 points. However, patients who only received the acetaminophen with ibuprofen had their pain relief reduced by 4.3 points, which is on the higher end of the average. So this study concludes that in certain cases, non-narcotic pain medication can be just as effective as narcotic medications. But there are some cases that opioids are needed and for pain relief. So the final case study, a 56-year-old male who had a history of daily opioid use for 10 years presented for an invasive orthosurgery. He was treated initially in the perioperative and postoperative timeframe with NSAIDs, ketamine, local anesthesia, and opioids. But pain relief was not achieved for this patient until the PCA pump was added to the pain control. So with a patient like this taking an opioid for a prolonged period of time, so 10 years in this case, the patient required more and more of the drug to achieve the same effect. And this is a major risk of opioids, is the tolerance and dependency that they can cause. But in this case, PCA offered a continuous delivery of potent opioid and the ability to dose for breakthrough pain. So it was effective in this case for this patient's pain relief. Is PCA safe? The error rate for PCA administration is less than 1% compared to 6.9% in other medications. The majority of PCA errors are attributed to operator errors, and then finally device malfunction, prescription errors, and patient errors. So with this study, we know that it is very important to thoroughly train the nurses and the healthcare providers that are using these PCA pumps to try and reduce the amount of errors. And this is just a summary of some notes about PCA versus other pain medications. And I believe that's it, and these are the references.
Great job. Why did you choose this topic?
I was kind of curious about why PCA isn't really used more often, because it's kind of an automated thing. The nurse doesn't have to keep going in and giving pain medication, but reading it, it does carry some risks, and I get now that it's only used in certain acute situations. So.
Okay, thank you, Austin. Good job. All right, everyone, this concludes our session. Excellent work on all of you. Y'all did a great job with presenting, and I also want to commend y'all on providing some really excellent questions to each other, and it was very nice to see all of your encouraging words to one another as well. So be very proud of yourself. You will need to, I'm going to stop the recording on this one, but you will need to